We are so excited that you are taking time out of your day to learn more about bioidentical hormone replacement therapy, a mouthful, in the form of pellets with BioTE Medical. I'm Jenny Bear with BioTE Medical. I work with North Austin Urology and help support them any way that I can to pass on the good news about pellet therapy. So without further ado, Dustin, go ahead and show yourself. Here he is.
Yeah, hey guys, thanks for joining in, and glad to have y'all. And we want to take this time, you know, when we see you guys in the office, a lot of times we don't have enough time to go over everything, and this kind of these little educational seminars give us a deeper dive, allow us to go through a lot of questions too. And so we'll have a little Q&A at the end if there's any questions that come up. So I'm Dustin Fontenot. I'm a physician assistant at NAU urology specialist. Been doing men's health and women's health for quite some time, particularly with the hormone replacement therapy. So I'm going to go ahead and get started here with the presentation. Let's see, share screen. Just going to take a second here. Jenny, does that look okay?
Yep, perfect.
All right. Okay. We're going to go ahead and get started. So I can move these down. Okay, so we're going to go through a bunch of slides here, kind of hit the highlights and hopefully answer a lot of you guys' questions. Obviously, we're going to be talking about hormone replacement therapy, why they're important, and what a hormone imbalance means. Some more things we hope to answer during this presentation. What do you need to know? Who can you or should you believe in, and what can you potentially do? As you can imagine, there's a lot of information on the internet, some good, some bad. And so hopefully we'll be able to answer some of those questions and maybe some of the myths as well. So what are hormones? Hormones are messengers. They're made by the endocrine gland. So we have all kinds of different hormones in the body. They all control different cells, different organs. They sort of, they call it work in a lock and key fashion, which means different hormones unlock different functions of the body. So this is kind of a question that we all think about. Do we age because we lose our hormones, or do we lose our hormones because we age? It's a great question. And I don't think anybody really knows the answer so much to it. How do you feel? So these are going through some emotions. You know, when you start declining in your hormone levels, obviously your quality of life can suffer. And you can go through all kinds of different emotions. So these kind of go for both men and women, losing the sex hormone. So a lot of these symptoms you may experience, you may have heard of. So the extreme fatigue, mood swings, anxiety, tension, irritability, poor sleep. That's a really big common one that we see. Memory loss, depression. You know, the brain is the largest testosterone receptor in the body. So there's a lot of psychological things that happen that a lot of people don't think about, especially with men as they lose testosterone. That's where we come from, the brain fog, lack of focus. Hot flashes, night sweats, that can happen in women, very common in women as they're going through menopause as well. And then, of course, the libido and the sex drive, as well as performance. So the BioTE method that we're talking about today is really is a system in which we replace hormones and balance the hormones that our bodies sort of decline as we get older. So both testosterone, estrogen, and thyroid hormone. Andropause. So this is the male version of losing your sex hormones as we age. Of course, the female version that is more commonly known as the menopause. So 20% of males over 50 have low testosterone, and I would say that it's probably higher than that. That statistic's a little tricky because there's a variable definitions of what's considered low testosterone. You'll see here common in men with diabetes, high blood pressure, sleep apnea. You know, those are your comorbidities. So anytime you have these metabolic syndromes, which you see there, those are often correlated with low testosterone levels. Low testosterone levels are also linked to early heart disease and is largely underdiagnosed. Testosterone, that's the main male sex hormone. So as you'll see, both in men and women, testosterone protects both the bones, the brain, the breast, the heart, and relationships, right? So that's kind of going back to your mood type of thing. Large amounts in men, small amounts in women, but women do need testosterone. It's very important. And in turn, men do also need estrogen, which we'll get into a little bit later. Every year after the age of 30, men are really losing about 1 to 3% of their testosterone production. Some of it's more rapidly losing than that. And women even quicker. And theirs just going to be more sudden, whereas most men is more gradual. This diagram is really looking at sort of the different levels of testosterone and where we see risk factors increase and where symptoms show up. So the lower the testosterone, really the point of this slide is the lower the testosterone level, then your risk of these erectile dysfunction, depression, all start going up as well. And it kind of works vice versa. By maintaining that normal testosterone level, you decrease your risk of Alzheimer's and sarcopenia, which is the loss of muscle mass, abdominal obesity, atherosclerosis. That's going to be your heart disease problems as well. So in turn, positive effects of maintaining the hormone levels. And again, this isn't, making you a Superman. This isn't increasing your testosterone levels to that of what we call supraphysiological. This is just maintaining that normal level as you age. Is we can see these improvements. Now, definitely not trying to oversell it. It doesn't mean that everybody's going to see every one of these improvements. Some guys will see, improved energy levels, improved sleep, improved focus, but it may not have a big impact on their libido, and it could be vice versa. So, but these are all potential things that we can see that can benefit. The things on the right hand of your slide there, that's going to be what I call kind of the behind the scenes, right? So breast protection, prostate protection, brain protection, heart protection. So those aren't things you're necessarily going to physically manifest and feel, but they're working behind the scenes to protect those important parts of the body. So menopause. So here's our more commonly known. So this is what the women go through. So andropause is a decline in sex hormones in men, and menopause is a decline in sex hormones in women. So symptoms all over the board with menopause, from the hot flashes to the moodiness, the irritability, and then some of those behind the scenes things that we talked about as well, as far as osteoporosis, the loss of bone mineral density. This slide is just indicating that heart disease much more prevalent in postmenopausal women. And again, we believe that's due to the fact that it's a decline in those sex hormones that do protect the heart, particularly testosterone, estrogen. So facts about estrogen. So like I mentioned earlier, large amounts in women, very small amount in men, has a ton of roles. So it does control the hot flashes. It does maintain your bone density. This is why, grandma falls and breaks a hip because her bone's in weak, because she's gone through menopause and she has no estrogen. So this benefit of maintaining your estrogen as you go through menopause is not only do you feel better, but you also are doing these behind the scenes. You're helping improve the bone mineral density kind of as best as you can, starving off that osteoporosis, obviously, as well as weight-bearing exercise and other things to help it. But it definitely, the estrogen is a major component. It's why, premenopausal women very seldomly get osteoporosis. So obviously the estrogen has a huge play in it. So positive effects on estrogen. So this has to do with, once you go through menopause, what will help by maintaining that normal estrogen level. And obviously just a reversal of what we just talked about. So maintaining that density, controlling the hot flashes, the collagen in the skin, that elasticity in the skin, memory, as well as some cholesterol impacts as well. So when we talk about hormone replacement, so after we go through either andropause or menopause, now the next question is, okay, so how do we replace it, right? So our bodies aren't making it, so now we got to somehow get it into the body. there's kind of two pathways you go down. So there's either synthetic or there's bioidentical. So synthetic, that's going to be your pills, your patches, your shots. And then bioidentical, pills, patches, cream gels, or pellets. So there's just the medicine can be formulated in different ways here. This slide talks about a study that was done in 2002 by the WHI. Basically, I won't bore you with all the details, but basically it came out and said, you know, estrogen replacement in women is terrible. It causes heart disease. It causes breast cancer. You're going to get blood clots. You're going to die. And so everyone stopped taking their oral estrogen, which was the most common form at that time. And that was it. It was at that point, estrogen replacement in women was terrible. And you just go through menopause and you had to deal with it. After the fact, the study was incredibly flawed. And unfortunately, many women went without and just kind of suffered through it. And that sort of goes into the whole quality of life issue. So these next few slides are going to talk about different forms of estrogen replacement in women. Patches. So these are patches that are put on. They last a variable time. I mean, some of them are daily, some of them are weekly, some of them are twice a week. It just kind of depends on your dose. They do have that trouble of absorption through the skin. So even with other hormone products like testosterone gels and things like that, you just can't, there's only so much you can get through the skin. And so that's sort of a downside of the patches. Creams or gels, I would say the biggest problem with the creams or gels, of course, is the imprecise dosing. So unlike a pill or a patch or something like that, when you're dealing with even the metered pumps, you know, you can still, it still isn't super precise. Short half-life, you're doing it daily. And then of course there is that risk of transfer. So it's on your skin, you can transfer it to pets, kids, husband, whatever. It also has estriol, which is different than estradiol. So the estradiol is the actual form of estrogen that does have all the heart and bone protection, and the creams unfortunately do not carry that. Injectable testosterone. So probably my least favorite way of doing this in a female. It is wildly inconsistent. I mean, you have these kind of ups and downs. You're doing really, really small shots that are hard to kind of measure out. It's going to always be synthetic. And it does have some negative impacts on your cholesterol. It's just super tough to manage in women and get a really great result out of it. I have very, very few patients, female patients, that do the injectable testosterone. So now we'll talk about the hormone replacement. So you'll see in that hand picture on the bottom right-hand screen, that is the actual size of the pellets. So they're super small. The little circle one you see, that oval disc, that is an estrogen pellet, and the cylinder-shaped one is more of that is actually a testosterone pellet. So these are natural plant-derived compounds. They last longer. So when we put them in, most women, we can get 3 to 4 months out of it. Men, we're looking at 6 months. And then the most important part of it is it does provide that steady stream of hormone in your body. So they're kind of, I would say they're the most physiologically similar to your body's natural hormone production, just because you're getting just a steady release. And it's super convenient. And it also takes the human error out of things, of you remembering to put a cream on a 24-hour basis or a injection once a week. This is just a little slide talking about the history. Really, the take-home point on here is that it's nothing new. It's been around since 1939. And the use of estradiol and testosterone pellets for symptoms of menopause has been around forever. This is a slide just depicting what I mentioned about the stability. So you can see there the oral, which is on a 24-hour half-life, up, down. If you happen to miss a day, you're traveling, forget your pill or whatever, you're going to plummet. And then the patches, you know, that would be the next best thing to the implant as far as on a consistency basis, but you're still going to have those ups and downs. It is not a linear release. And then the pellets is going to, of course, provide you the most stable release, which is that green line there. So what's the BioTE method? So BioTE is really the right kind of hormone. So bioidentical versus synthetic, the dosing. So we do individualized dosing. So it's not you're a female, this is the dose you get. We take a lot of factors into consideration: your age, your weight, your activity level, of course, what your actual numbers look like, your hormone levels, and then the right delivery system. So the BioTE method, pellets obviously provide the most consistent delivery of the hormone. So this slide is just kind of reconfirming some of those things I mentioned earlier. It's been studied quite a bit. When I talk to my patients, I say, look, here's the deal. I mean, the pellets, in my opinion, are by far the best way. It's the most convenient. And men, we're only doing it twice a year, and women, we're doing it every 3 months. It provides the most stability of the level, so the least amount to get ups and downs, and also the least amount of side effects. So with some of the more common side effects, especially in men with injectable testosterone, the elevation of red blood cell counts, the elevation of estradiol levels, you rarely see it with the pellets. And that, again, just goes back to the stability of it. You're not getting those big spikes that we can get with the other methods. So this study is just this slide is really just talking about the notion that there's a belief out there, and that goes back to that WHI study, that the use of testosterone or estradiol in women increases the risk of breast cancer. That has not been panned out. In fact, that the studies are starting to show exactly the opposite. So there is no increased risk of breast cancer in women for using the implantable pellets. And this is just a study that talks about that. Bone health. So this goes for both men and women. I mentioned earlier, osteoporosis develops as the body stops producing estrogen. So in men, we don't have ovaries. So the way we get estrogen is there's an enzyme in our body called aromatase. And so some of the testosterone we make converts through this enzyme to estradiol. So from a secondary mechanism, as our testosterone falls, therefore our estrogen levels fall as well. And that's what leads to osteoporosis in men. So by maintaining a normal testosterone as we age for men, it also maintains that normal estradiol levels, which we hope will then keep up with our bone mineral density as well. And what's important about keeping up with your bone mineral density is that you don't fall and break a hip, or when you do fall, you don't break a bone. Both estrogen and testosterone can stimulate the precartilage cells, which we think will help either prevent or reverse some of the development of this arthritic tissue. So that's a really neat study that we've been looking at. Brain health, I mentioned earlier, testosterone, the largest testosterone receptor in the body. So you can imagine that if you have this big receptor of a hormone and you go 40, 50 years with sort of a diminished amount of this hormone to this receptor, what kind of causes or what kind of problems it can cause. So men with low testosterone, 3 times more likely to develop Alzheimer's disease. So this kind of goes in that causation and correlation thing. We haven't completely connected the dots on this, but the statistics are there that show that sort of, if you do have low testosterone as you age, you're going to be 3 times more likely to develop it. Heart health, another benefit of maintaining these hormone levels, decreasing the total cholesterol and LDL and increasing HDL. So, when we talk about heart health, really what we're talking about is the decrease in that bad cholesterol, which helps decrease the amount of buildup we get in those coronary arteries, which then in turn will lead to less major cardiac events. And then as well as decreasing in fat mass, right? So the more lean our bodies are, then the less our heart doesn't have to work as hard, which will then improve our heart health there. So in men, testosterone pellets have shown to decrease your total cholesterol and LDL. LDL is the bad cholesterol, increase HDL, which is the good cholesterol, and decrease the triglycerides. Also, it helps improve that lean body mass, which the more lean body mass you have, then the higher your metabolism is, which means that just the easier it is to stay lean. So what are the risks of pellets, right? We've been talking about all the benefits. So What are their risks? So fluid retention, most common after your first insertion. And that's going to be due to a spike in estrogen. So it's a temporary spike. It does go down. What I think is happening in the body is that, it hasn't seen this much testosterone in a long time. So it kind of doesn't know what to do with it. So it dumps a lot to estrogen. And so that can cause fluid retention in men. And then on the female side, just dosing that estrogen for the first time just can cause their bodies to start hanging on to fluid. That does go away. The swelling of the hands and feet, again, due to that fluid retention. So the fluid's got to go somewhere. So you tend to see it in the hands and feet. Breast tenderness, nipple sensitivity, estrogen related completely. Uterine spotting, bleeding, estrogen related. Pellet extrusion happens. It's pretty rare. I think I've never seen it in a female. I think my pellet extrusion rate in men are less than 2%, 3%. I think there's some people that their bodies react unfavorably to the stearic acid or some of the other agents in the pellet that and the body just kind of views it as a foreign object and tries to spit it out, but pretty rare. Facial breakouts, that's sort of the acne. That's kind of like going through puberty again, right? So you get this big, all of a sudden your hormones are higher again, and that can lead to some acne, as well as reduction in sperm count. Generally, our patients that we're pelleting are not actively trying to conceive children. So this is just kind of a take-home slide here. It can happen in men and women at any age. Certainly not all therapies are equal. So I think that, every patient's different, and what may work for them may not work for another person. It's hormone therapy is certainly an art. It's as much as it is a science. And that goes into the one size a fit. I mean, it just doesn't work out that way. All of the people that do BioTE are actually certified through the BioTE company. We go through a big training course and continue to train in the BioTE method. Another key fact is the normal labs. So that's kind of interesting because a lot of people say, well, my doctor said my labs were normal. Well, if you knew kind of where those normal ranges came from, and that each individual lab may have a different range, it tells you that they are kind of arbitrary. So, if you're not feeling well and you feel like you're having these symptoms, but your doctor told you, well, my labs are normal, I would probably have a second look at those because they may not necessarily be normal for you. And then, it's not just about testosterone, estrogen that we talked about. There's vitamin D3, which is actually a hormone, your thyroid hormones, B12, et cetera. So, a full kind of workup panel to look at everything top to bottom is warranted before we start treatment. And I think that's the end. So let me flip it back to Jenny. I'll stop my share there. And you got the floor, Jenny. You're on mute.
Sorry, I thought I pushed it. What I thought we would do is open it up for a few questions, and then we'll go over the tantalizing offer that NAU is offering. Let's see. Oh, we do have a question. What is the downtime after insertion, Dustin?
Great question. So I have two rules that I give patients. So no lower body activity for 7 days. So that's running, jogging, anything that's going to cause repetitive movement of the lower leg, glutes, and then no soaking. So pool, hot tub, river, lake, stay out of that. Showering is perfectly fine. It's just while we make a tiny little incision. So while that's done, while that's healing, then we want you to just stay out of the water.
And we like to call it an exercise vacation for a week for men. 3 days for ladies.
Right.
Let's see. I'm trying to think of other questions why don't you think of a couple of questions, Dustin, that maybe people often ask you in the office?
Well, we went over a ton.
Yeah, we did. I'm trying to think of the questions that people most often ask me.
We got one that popped up in the chat.
Okay.
Does it hurt to insert? So we use a little numbing medication to numb you up beforehand. So, you will feel a little pinch from the numbing medicine. Not nearly as bad as having a dentist put a needle in your gums, but it is a little numbing medicine back there. Once it's numb, then you don't feel anything. There is, in men, with women, I would say no, but with men, there's a little bit of soreness for a couple of days afterwards. It just feels like a little muscle soreness, but that's about it. And you're not doing lower body activity anyway, so it tends to heal up just fine.
And Dustin, why don't you tell them, in case they don't know, about your awesome podcast on your website?
Oh yeah, so Armor Men's Health is a podcast. We're also on KLBJ. If you guys are local to Austin, we're there on Saturdays. But we have all of our sessions are recorded as well. So if you do miss any of our recordings, you can catch them on our podcast. And we talk about all kinds of things, not just testosterone, but anything urology related, from men's health to women's health to kidney stones to fertility to vasectomies, everything in between.
Which is awesome. And I've listened to 3 of them so far, and they're great. And everybody at your practice, which is what I love about your practice, has a really great sense of humor.
Yeah.
You do have to talk. I think you have to have a sense of humor when you're talking about a lot of the issues that come up. Dustin, maybe can you address why we use supplementation along with the pellet therapy?
Right. So we use targeted supplementation with the pellet therapy as sort of an adjunct. It kind of helps fill in all the gaps and complete the circle. So we don't believe in just a shotgun approach to supplementation where, everybody take this, or whatever. We're going to look at the individual. If the vitamin D is low, we're going to prescribe a certain dose of vitamin D. We use a product called DIM, which helps sort of metabolize the estrogen in both men and women. And it just helps sort of accelerate the benefits of the pellet therapy. There's a couple other ones coming in here through the chat.
There are. Let's see. So let's talk about, does insurance typically cover the cost? That's a very common question.
Very common. Yeah, so they do not. And you're more than welcome to try to fight it with your insurance. We have people all the time saying, well, let me try to get reimbursed. And that's fine. You're obviously more than welcome to. But largely, hormone replacement in general is poorly covered by insurance. So this is going to be a cash procedure. The cost for women is $300, and the cost for men is either $600 or $700, depending on what dose we give you.
And Dustin, can I throw something in?
Sure.
I think that at your practice, you often run the consult through their insurance and the lab work through their insurance.
That's right.
You have a cash pay option as well, right?
That's right. Yeah, for both. So office visits, lab work, all that kind of stuff is billable through insurance, but the actual procedure and the pellets themselves are non-insurance.
And so we have a question from Rick. And what does vitamin D3 and D4 do? And how much does it cost? I'm not sure if you meant that for the insertion or for vitamin D, but.
Okay. Yeah. I was going through those questions too. There's several above his. So vitamin D3 is really the most important one there. It is, what does it do? So it's a hormone. It plays an important role in a lot of different things. The most important role it plays is we know it does provide some cancer protection. Which kind of cancers, we're not really sure. There's also there's a 20% in all-cause mortality in people that have low vitamin D versus those that don't. It's a super easy, relatively inexpensive supplementation. So this is going to be an oral supplement that you take daily. How much does it cost? I mean, I think a month supply might be $25 or something. I don't know off the top of my head, but it's relatively inexpensive. But this is just going to be a pill form, and there are these little gel caps that you take. I'm just going to start up here at the top, Jenny. I want to try to get some of these other questions answered.
I think you got most of them. There's one from Elaine that you didn't get to yet. Yeah.
So then there's another question about HGH levels in men. This does nothing to affect HGH levels in men. HGH stands for human growth hormone. There are some natural ways to increase it, and those are really just living healthier, maintaining normal weight, getting the 8 hours of sleep, exercising, all those kinds of things can help improve HGH. Otherwise, you're doing HGH supplementation. And there's a couple ways to do, I mean, that's kind of beyond the scope of this discussion, where it gets into some of the peptides that we can use to increase HGH, or just giving somebody HGH, human growth hormone. That treatment is very expensive. It's about $1,000 a month. It's not a treatment we offer, but we do offer some of the peptides that help stimulate your body to produce more of its own HGH. And those are a lot more cost effective. And that's something that we can talk about as well. It's just a little too in depth for this discussion. What is the effectiveness compared to injections in men? So I kind of touched on that during the presentation. It also kind of depends on what you define as effectiveness, right? So if you define effectiveness as numbers on a piece of paper, sure. I mean, I can get any level I want to achieve, a number on a piece of paper, with a shot or with a pellet. If you're talking about the stability or the consistency of the level, well, there's no comparison. I mean, the pellets are going to be a lot more stable. The injections, if they're done weekly, you're going to get a spike about 2 or 3 days in, and then kind of come down day 4, 5, 6, 7. So you're sort of doing this up and down, up and down, up and down every week. With that being said, I have a lot of men that are happy with injections. I mean, there's people that have been doing injections for years and they love it. So, can they be equally effective? I mean, I think it's up to the patient. There's patients that love it and there's some that hate it. But as far as achieving a certain testosterone level, I can achieve a testosterone level with both. It's just a matter of, I can achieve a stable level of the pellets, can only give you a range with the injections, just because it's going to fluctuate so much. Breast enlargement in men. So that's a condition called gynecomastia. It certainly can happen if the estradiol levels get too high for too long of time. I don't see that with any of my patients, simply because I follow them closely and we're doing regular blood work. So if that ever happened, I would be on to your high estrogen well before any breast tissue would ever develop. And we have ways of reducing estrogen with some medications and things like that. Again, the estrogen issue is a lot less frequent and a lot less common with pellet therapy than with some of the other forms. It's still a possibility though, so we still certainly watch it and check your estrogen levels, but just not really an issue. Now, if you're doing this on your own and you're using testosterone from some dude in the locker room at the gym, and you're just kind of willy-nilly it, then yeah, for sure. I see that all the time in patients that come in. Okay, here's a good one. If you're considered high risk for breast cancer and been told to be cautious taking estrogen and have had a complete hysterectomy, do you still recommend estradiol and testosterone pellet therapy? So this is a great question. This is actually a kind of a complicated one, and you can ask a lot of different people and they'll give you a lot of different answers. I think it would probably get down to what high risk means for you. Is that like a direct, first degree relative, like a sister or a mother? Are you testing positive for the BRCA genes and that's what you're considering high risk? So what I would tell somebody in this case is the testosterone pellet therapy is totally fine. It's whether or not you want to treat with estrogen. And I think this kind of comes into that shared decision making where, you would want to loop in your gynecologist or oncologist or whoever you're discussing these things with, as well as whoever you're discussing your pellet therapy, and kind of just have a shared decision, look at all the risk and benefits. I think it also depends on how symptomatic you are. I mean, if you're just struggling and you're, just miserable, then okay, cool. So you're going to live the rest of your life without hormones and be miserable. And well, you didn't get breast cancer, but you were miserable, right? So, or vice versa. If you had just mild symptoms and you kind of wanted to do it just to do it, then maybe that risk might be a little too high for you. And everybody's risk tolerance is completely different. And there's ways to mitigate risk, right? So you can do more frequent mammograms and these kinds of things and ultrasounds to help mitigate that risk. So I know I probably didn't answer your question, but I think you need a little bit more information about the patient. And that is a complicated question that I think multiple people need to be involved in answering that decision. I mean, there's some people that are considered high risk for breast cancer that have bilateral mastectomies prophylactically, because they're at that such a high risk. So I think it really comes down to the individual. We answered the vitamin D question. Okay, so the cost it's $600 to $700 for the procedure itself, not per pellet. No. Yeah, that would be a little outrageous. No, that's for the entire procedure. So you're looking at that cost about twice a year. Vitamin D does help absorb calcium. That is absolutely correct. Yep. Will this treatment cause some breast enlargement? We talked about that, the whole breast enlargement thing. If the male did get breast enlargement, will it go away after treatment adjustment? So that depends. So some males will get these like little nodules that I can usually get to go away with some anti-estrogen medication. But if it's prolonged, if you went a long time with estrogen, which again, not going to happen with any of my patients because I draw labs on them. But if you were somewhere else and maybe they weren't drawing as many labs on you, once the breast tissue lays down, it does not go away. It's permanent and it requires surgery to have it removed. And that's generally done by a plastic surgeon. But that's that's really high estrogen levels for probably at least 6 months. And then it can lay down. And yeah, unfortunately, once it's there and it will have to be surgically removed. I think that's it for the questions, Jenny. Yeah, I think it is. So the special offer, and hopefully you guys can see that on my screen. Do you see it? Dustin, do you see it? I just want to. Yes. Okay, great. So you get 20 for brand new BioTE patients. You get 20% off the insertion of the pellets and your supplements to optimize your hormones and boost your immune system. And if you're a recurring patient, so let's say maybe you had BioTE at one point in time, you went back to injections and you want to try the pellets again, that is 10% off the insertion and the supplements. And then for those of you who are on the call that are ready to schedule or ask more questions, we would like you to call Donna McBride at the practice at this number or email her at naurology.com. And we so appreciate you taking time today to come and learn more about hormones. And I'm just going to give one more chance. If anybody has any further questions, I'll see them in the little chat box and just make sure that we got everybody's questions. Okay, I think you answered all these questions. There's one that popped up here about the yearly versus pellets. Yeah, so the yearly cost of so we talked about the yearly cost of pellets. You're looking at $1,200 to $1,400 for the pellets for the insertion versus cost of injections. That's a tough question to answer just simply because sometimes the injections are covered by insurance, sometimes they're not. Just depends on the insurance. I would say more likely, I would say that they're not covered by insurance. And it's like the way we do injections is basically you're provided a prescription for the medication, and then you take that prescription to your pharmacy of choice, and then they will fill it for you. So if it goes through your insurance, then you're going to be subject to it, your deductibles, your copays, whatever. If it doesn't go through your insurance or it's not covered, then you're going to be subject to whatever the cash pay price is at that particular pharmacy. And whether you go to CVS or Walgreens or HEB or wherever, everybody's prices are going to be across the board. The other difficult part about answering that question is that everybody's dose is different on injection. So, if you're on a tiny dose, then your cost is going to be less because you're using less medicine. If you're on a higher dose, then it's going to be more. Because you're going to be using up more medication throughout the year. So with all those variables, it's really hard to say. On average, you'll probably pay a little less in a year for the injections versus the pellets. But it's kind of apples to oranges, really. I mean, it's not quite the same exact thing. But yeah, the insurance coverage on the injections it's really shisty, and it's super difficult for us to try to get it done. Insurance is just really not interested in paying for hormone therapy in general, unfortunately.
Dustin, I have a question. Since every practice is different, can you explain their journey? So let's say they're interested in the pellet therapy. Can you walk them through the steps of what they do?
Yeah, so if they're a brand new patient to our practice, they'll come in, meet one of us. If they have blood work, great, we can go off that. If it's recent, I would say within the last 3 months. If they don't have blood work, then we'll go ahead at that appointment. We'll go through all the history and everything with them, and we'll draw all the labs that we think are needed, get those sent out. And then typically we can do it 2 ways. If you've already made your mind up, you want to do pellets, you're in, then your next appointment we'll set up to just do the pellets. And before we pellet you, we'll go through your lab work and review everything with you and make sure, we're still on board to do this. If you're kind of on the fence and you don't really know for sure, then we'll set up another appointment in which we'll go over all your lab work with you. A lot of times we can do that over the phone too. Go through all the results, kind of see what needs to be fixed, what's deficient, what's not, come up with a treatment plan, talk about all of our options. And then at that point, then we can set up a time to implant the pellets. So it just kind of depends on how you come in. Obviously, some steps can be skipped if you come in with lab work already drawn. And if you already kind of have an idea of what you want to do, then we can sort of bypass some of these other intermediate steps.
Can I add or have you clarify? But, when people hear the word procedure or insertion, sometimes they get a little freaked out. But in all honesty, let's say for the ladies, it may take 5 minutes. It may actually take like 3 minutes to numb and like less than 2 minutes to actually do the insertion of the pellets. And a guy may be like what, Dustin, 15-minute appointment, 20-minute appointment, actually do the insertion? Probably
insertion is taking about 10 minutes on a guy.
Mm-hmm.
Yeah, it's a really easy, it's a super easy process. But yeah, the females are a piece of cake. The guy, I mean, to give you kind of an idea, women, we usually are putting in 1 to 2 pellets. Our guys, max, we're putting in almost 12 pellets.
Right.
So that's why the men are a little bit longer. We have to space the pellets out a little bit more. But either way, you're 10 minutes max, generally what it's taking us to get it done.
And I don't know if you covered this, but did you cover exactly where the pellets go? Because a lot of people ask that question.
I didn't. So the primary place we put them is going to be in your hip. So not sort of on the side, but right high butt cheek. So you don't sit on them. So when you sit, you're not sitting on them. And there's some alternative placement sites as well. But for the most part, we're putting them up there in the hip.
Yeah. Yeah. So that way it doesn't get on your belt line and it doesn't get in the way of sitting. So he's right. There's like perfect placement on everybody's cheek.
Yeah.
So great. Well, thank you so much, everybody, for participating. And hopefully you wrote down Donna's information to call the office and get yourself set up. And I hope that you have wonderful results, whatever therapy you decide. And any last words, Dustin?
No, thanks everybody for joining. We enjoy doing these kind of educational deals. We don't have enough time. Then we got 15 minutes in a visit appointment. There's no way we can go over this kind of stuff. So it's pretty cool to be able to do these.
Let me see one more. We got one more. Oh, well, you're welcome. Thank you. Well, everybody have a great rest of your day. And I'm going to be sending the link to Donna and Dustin. So if you have a friend or a spouse or somebody that you would like to watch this recording, we're going to send that recording out to you. So thank you so much. Have a great rest of your day.
All right. Thanks, guys.
Thank you. Hey.